Today we are going to talk on the problem-based seminar 4, where we are going to touch on the neonatal jaundice, neonatal anemia, neonatal thrombocytopenia, hemorrhagic disease of the newborn. So next. So my name is Aina, and I'm going to talk on the neonatal jaundice. Next. So this is basically the table of content of what I'm going to discuss today on neonatal jaundice, where first I will talk on the definition, and then I will discuss on the bilirubin metabolism, and then approach to the neonatal jaundice, and also investigation and also management. Okay, definitions. So what is neonatal jaundice? Neonatal jaundice, or other term that we use is neonatal hyperbilirubinemia, is actually one of the most common medical condition that happen in the newborn babies. So it could be unconjugated causal or conjugated causal. So according to the Nelson textbook pediatric, neonatal jaundice is defined as the yellowish discolorations of the sclera, skin and mucous membrane due to the elevations of the serum bilirubin. The jaundice usually occur within the first months of the baby's life. And according to the pediatric protocol for addition, generally all baby will have a transient rise in a serum bilirubin, but only 75% will usually show visibly the jaundice. And the jaundice is clinically detectable when the serum bilirubin levels are more than 85 micromole or 5 milligram per deciliter. Okay, next. So it is actually important to identify baby who have the high risk of severe hyperbilirubinemia, as we afraid that they will develop adverse neurodevelopmental sequelae like chronic terrors and bilirubin encephalopathy. So that's why baby, they are more likely to develop a severe hypobilirubinemia. They will have the following risk factor, such as late prematurity, low birth weight, jaundice in the first 24 hours of the life, mothers with a blood group O or rhesus negative, G6PD deficiency, rapid rise of the total serum bilirubin, sepsis, because sepsis greatly increases the risk of bilirubin toxicity, lactation failure, exclusive breastfeeding, high pre-discharge bilirubin level, cepha hematoma or bruises, babies of diabetic mother, because they can deliver the macrosomic babies, and the family history of the severe neonatal jaundice in the sibling. Okay, next. Next, we go to the general, briefly on bilirubin metabolism. So just recall back our knowledge that we have before this. In bilirubin metabolism, what we have is that we have red blood cell. So red blood cell, the lifespan of the red blood cell is approximately 120 days. So what happened is that once the red blood cell has completed the cycle, the red blood cell will be broken down into the organ like spleen and also liver that contain numerous macrophages. And when the red blood cell has been taken by the macrophages, it will be further broken down into heme and also globin. So the globin will be broken down to the amino acid that will be used by the body, and the heme will be broken down into iron and biliverdin by the heme oxygenase. Okay, you can refer to the next picture. Okay, this one. Right. We have just now the globin and also the heme. So the heme will be broken down into the iron, as you can see, and the biliverdin will be the heme will be broken down into biliverdin by the heme oxygenase. So the biliverdin, what they do is that the biliverdin then will convert into the bilirubin by the bilirubin reductase, and it is now in the form of non-conjugated bilirubin, which is insoluble. So this unconjugated bilirubin, then it needs the albumin in order to be transported to the liver. So in the liver, the bilirubin will be then conjugated with the glucuronic acid by the enzyme called glucuronyl transferase, which is now it is in the water-soluble form. So once it is in the liver, it is in the water-soluble form, it will be then transported to the biliary channel into the duodenum, and through the duodenum, it will then reach the colon. And in the colon, the bilirubin will be acted up upon number of organisms that they have in the colon, and will be converted into urobilinogen and also stercobilinogen. Majority of this compound, the urobilinogen and stercobilinogen, majority of the compound will be excreted as the feces, in the feces as a stercobilin. That's why it will impart the yellow color in our feces. But then they say that 10 to 15% of the compound will be reabsorbed back in the blood, and some of the part will reach the liver via enterohepatic circulation. And there are few percentage of the reabsorbed compound will reach the kidney and they will be excreted in the urine in the form of urobilin. Okay, next. So this is a type of bilirubin where we are discussing unconjugated and conjugated. Unconjugated, another name is indirect. Conjugated is direct. Unconjugated, where it will bind to the albumin in the blood. Conjugated, the bilirubin will conjugate with the glucuronic acid and become conjugated. Unconjugated, lipid soluble. Conjugated, water soluble. Unconjugated, usually it can cross the blood-brain barrier and cause toxicity in the brain. Conjugated, it will be excreted in the urine and stool, and usually it does not cause toxicity in the brain. Okay, next. So this is the causal of the neonatal jaundice. So I divided into three, which is jaundice that start at less than 24 hours of age, jaundice start at 2 days to 2 weeks of age, and jaundice that start more than 2 weeks of age, of which we call it as prolonged jaundice. So according to the Sunflower Illustrated Pediatric Textbook, it says that if the jaundice start within 24 hours of the birth, usually it results from the hemolysis, such as you can see, rhesus incompatibility, ABO incompatibility, G6PD deficiency, and also spherocytosis. And the jaundice also at birth, it can also be caused by the congenital infection. So for the jaundice at 2 days till 2 weeks, they occur 2 days to 2 weeks of age, usually is physiological jaundice. So as you know, physiological jaundice, it is a benign jaundice actually, and it occurs in almost all babies. So in physiological jaundice, it is actually happen due to the excessive bilirubin production, due to the high hemoglobin content, and there's a short red blood cell lifespan in newborn baby, and also poor bilirubin clearance, mean the liver is immature in physiological jaundice. The physiological jaundice, however, as I said just now, is benign, but it can be exacerbated by certain conditions, like if the baby has inadequate intake, has cephalohematoma, and also bruises. Means if it is increased, it can lead to bilirubin encephalopathy. So another thing, we have jaundice at more than 2 weeks of age, or we call it as prolonged jaundice. Some of the examples are breast milk jaundice, septicemia infection, which is commonly urinary tract infection, hypothyroidism, hemolytic anemia. And for conjugated, we have biliary obstruction like biliary atresia, coliacal cyst, and also infection like neonatal hepatitis. Okay, next. This is another classification of neonatal jaundice where we can divide into conjugated and also unconjugated bilirubin. Okay. Next, this is a time frame for jaundice in neonatal. Okay, next. Right, this is a table where we differentiate between pathological and also physiological jaundice. So physiological jaundice is the jaundice that occur after 24 hours of life, while pathological jaundice, usually it occur within 24 hours of age. And the physiological jaundice, usually the total bilirubin rise less than 85 micromole per liter per day, and pathological jaundice, the rise will be more than 85 micromole per liter per day. The maximum intensity for the physiological is 4th to 5th day in term and 7th day in preterm, while for pathological, usually the jaundice will persist after 2 weeks in term, or in preterm, it is 3 weeks. Total bilirubin less than 257, for pathological more than 257. And physiological jaundice usually clinically not detectable after 2 weeks in term and 3 weeks in preterm, while pathological jaundice, usually they will presented with clear color stool, dark color urine, and conjugated bilirubin more than 25 micromole per liter. Okay, so how do we approach neonatal jaundice? So when a baby presents with neonatal jaundice, it is actually important to identify the risk factor and the severity of the hyperbilirubinemia. As such, we will ask on the age of onset to determine the probability causal of the jaundice. We ask the mother, in regards for the mother, the history of previous infant with neonatal jaundice, chronic teres, neonatal death, G6PD, and consanguinity. For birth history and antenatal history, we will ask on the we will ask on the prematurity, because the incidence of hyperbilirubinemia increased with prematurity, maternal blood group and result status, maternal diabetes mellitus and gestational diabetes mellitus, whether the mother got infection or not, touch infection, traumatic delivery or perinatal asphyxia. And others, we could ask if there's any presence of abnormal symptoms in the current baby, such as apnea, difficulty feeding, feed intolerance.
Presenter, why you mentioned it is more in premature? Why?
Why? Because the CPG says so, doctor.
Why? Anyone else? Anyone has any idea? Why jaundice is more common in premature babies?
Immature liver.
The liver is immature.
The liver is not matured yet.
Yes, true. Because of immature liver, that's the reason why the liver is not mature enough to conjugate bilirubin. That's the reason why. All right, fine. Proceed.
Right. So another history that we like to ask on, we should also ask on the complication of the hyperbilirubinemia, such as if we suspect the patient has developed acute bilirubin encephalopathy symptom in different phase of presentation, as you can see. Okay, next. So another way to determine the probability whether the bilirubin is conjugated or not conjugated from the history is that for unconjugated, we could ask on infant feeding pattern, feeding intolerance, family history of blood group and results, G6PD, hemolysis, drug history, small gestation age, and also birth trauma. For conjugated hyperbilirubinemia, we could ask whether the patient presented with a dark urine color, like stool, jaundice more than 2 weeks, the prolonged jaundice, maternal and perinatal history, and family history of jaundice, liver disease, and metabolic disorder. Okay, then. So then we go to the physical examination. Usually for jaundice, we can observe the jaundice easily by blanching the skin with one finger. And usually the jaundice will tend to start on the head, cephalocaudal, means the head and face, and then spread down to the trunk and also the limb. So generally we will look at the current weight and the percentage of the weight loss, the signs of sepsis, the hydration status. For the head, we look for the cephalohematoma, subaneuritic hemorrhage, face, plethora. For the eyes, look for the conjunctiva pallor. For the skin, we look for the PTK. And for abdominal examination, we could look for hepatomegaly as a sign of the infection. Other sign that you could look for is the sign of the bilirubin encephalopathy, which I didn't put here, such as hypotonia or hypertonia, seizure, opistotonus, means the state of hyperextension and spasticity of the baby position, retrocolis, and high pitched cry.
Arching of the back.
So another parameter that been highlighted in the CPG guideline is that to examine, to measure the adequacy of the breastfeeding, because it says that the dehydration could worsen the jaundice. So next. So we assess the breastfeeding parameter by looking at the urine output, the appearance and the frequency of the stool, the baby color, alertness and tone, the weight, the number of the feed that happened last 24 hours, the behavior of the baby, the sucking pattern, the length of the feed, baby behavior after the feed. Okay. Okay, next. All right, one of the consequence of the neonatal jaundice is acute bilirubin encephalopathy. So that's why we need to assess the acute bilirubin encephalopathy. So in the term baby, we usually use the bind score to quantify the severity and the progressions of the baby. where we will evaluate them whether they are in advanced stage of ABE, moderate, or a mild ABE based on this component, as you can see in the table. But if the baby is in preterm, usually we will use the auditory brainstem response, or ABR. So ABR here is like a type of a screening hearing test that's been done in a newborn. Briefly described, it's just like a system that will record the brain wave activity. Okay.
Again, repeat.
ABR.
Okay. Okay.
Okay. Nak repeat balik ke sana?
It's okay. Proceed.
Okay, alright. Okay. So then we go to the okay, and following the PRITS protocol, they had mentioned on the methods to detect the jaundice. So we know that appearance and the progression of jaundice usually tends to occur in a cephalocaudal manner, right? So they highlighted the method to detect the jaundice, of which we use the visual assessment called Kramer's rule. So this Kramer rule provide a mechanism for the clinical assessment of the jaundice severity by measuring the proportions of the skin that is involved from head to toe. Like you can see, head and neck, level 1, upper trunk, level 2, lower trunk and thigh, level 3, arm and lower leg 4, palm and sole 5. And according to the level of the visual, the Kramer rule, it will show the range of the serum bilirubin. However, it is actually difficult if the baby is darkly pigmented baby. So from what I read, it said that all infant, if there's a severity of, if we question the severity of the jaundice and they have the risk factor, then we should also do transcutaneous bilirubinometer and also total serum bilirubin. Okay, next. So according to the CPG, they say that in baby with severe hyperbilirubinemia, an early onset of jaundice that happened less than 24 hours or rapid rise of total serum bilirubin more than 8.5 micromole, we will do a further laboratory evaluation to know the underlying cause and extent of hemolysis, which include the G6PD, the mother and the baby blood group, direct home test, full blood count, plus minus with the peripheral blood picture, reticulocyte count, and a septic workup if we suspect the infection. All right, for the management, okay, next. So this is basically the So this is basically the algorithm on managing the neonatal jaundice. So we look at the baby. If the baby presented with neonatal jaundice, which is more than 24 hours or less than 24 hours. If less, then we could suspect it is a pathological jaundice, so we admit it. If it is more than 24 hours, then we assess the risk factor first. And then we look at the criteria to for the baby in order to admit to the hospital. Okay, next. So this is the indication to be referred to the hospital. The indication to be referred to the hospital is when the baby has a jaundice within 24 hours of life. The jaundice happen below umbilicus. The jaundice extended to the sole of feet. Family history of significant hemolytic disease or kernicterus. Unwell infant with a jaundice. Prolonged jaundice of more than 14 days. Infant with conjugated hyperbilirubinemia. And if the infant with unconjugated, we can be investigated and referred only if the jaundice does not resolve. Okay. In the management of the neonatal jaundice, usually our goal of management is we want to prevent the complication. As such, we want to prevent the kernicterus. So one of the management is phototherapy. So the aim of phototherapy is to lower the concentration of the circulating unconjugated bilirubin to a level of which our central nervous system deposition is minimized. So this is we have several types of the phototherapy, such as fluorescent tubes, LED, fiber optic, and halogen bulbs. And when we do the phototherapy, usually how we do the phototherapy is that we will place the baby in the supine position with adequate exposure. Then we will expose the maximum surface area. We will apply the iPad and also gonadal protection. We will monitor the baby 2 to 4 hourly, and we will also monitor the hydration status. So note that when you do the phototherapy is that when you do the phototherapy, the baby should be regularly monitored for vital signs, including the temperature and also hydration status. The baby should be adequately exposed, and baby eye should be covered to prevent the retina damage. The breastfeeding should be continued, and when we take the blood or when we feed the baby, we turn off the photolight and just remove the iPad. This is the complication of the phototherapy, which is dehydration because of the insoluble water loss. Baby could be irritable or lethargic, skin rashes, overheating, retinal injury due to the exposure of the UV light to the eye, adverse effect on the cell growth, oxidized essential fatty acids, decreased vitamins and calcium in the premature infant, and also development of the tanning or bronze baby syndrome. So another one we have is management is exchange transfusion, or ET you call. So usually exchange transfusion is indicated if the intensive phototherapy is failed, and if the baby has developed severe hyperbilirubinemia that could lead to the risk of kernicterus. So what type of the blood and how much blood do we exchange in the exchange transfusion? Usually we use the fresh whole blood, preferably less than 5-day old, or we will reconstitute the packed red blood cell and the fresh plasma frozen in a ratio of 3 to 1. Volume, how much blood to exchange is that we will exchange 2 times the infant total blood volume. For the complication of the exchange transfusion, because complication can happen during transfusion, it could be related to the blood, to the catheter, and also to the procedure. If blood, it could be due to transfusion reaction, metabolic instability, and also infection. If catheter, it could be due to hemorrhage and also vessel perforation. For procedure, necrotizing enterocolitis, hypertension, and others could be thrombocytopenia or graft versus host disease. Okay, done.
Wait, any question to the presenter? Okay, go back to your first slide. Apa question to the presenter?
Okay, Aina, I have a question. What's the total duration of like one session of phototherapy, or how do we determine if the phototherapy is done?
Hold on.
Macam mana?
Kejap ada tulis tanya kat mana. Usually for the phototherapy, we will expose the baby about 15 the light 15 to 20 cm from the baby, and the light is the distance is 15 to 20 centimeter. And tak sure lah doktor.
Anyone has any idea? So basically phototherapy, you give, there's no, you don't give phototherapy for specific duration. You give phototherapy as long as the child needs lah. So when you give phototherapy, the idea is the bilirubin should go down. So and then you decide some other, you can go, sometimes we give intensive phototherapy, sometimes we give just single phototherapy, and then we taper down until we are able to switch off the phototherapy when the SB serum bilirubin level falls clearly below the phototherapy level, because the level, it differs according to the risk factor and according to the age of the child. So for example, child less than 24 hours, there's the level will be lower. The older the baby is, the higher the level that we can accept for phototherapy and also for exchange transfusion. You look at the PBS protocol, there's a clear level for phototherapy and also for exchange transfusion. So we follow according to that guideline. So if you look at the our pediatric protocol, the level is actually lower than what you see in other references. I think if you look at NICE guideline for UK, the level is much higher than what we have here. So it differs. Okay. My question, why do we do phototherapy? What does phototherapy do? Mana presenter?
Yes,
Kenapa phototherapy?
we use phototherapy because we want to excrete the bile without conjugation, without the need to conjugate
Excrete the
bile.
bile and bilirubin is totally different things. Bile is bile. Bile is you get bile from your gallbladder.
I mean bilirubin excreted in the bile.
Not really. You don't excrete bilirubin through your bile.
Oxidize the bilirubin.
To what?
The phototherapy oxidize the bilirubin, so it becomes more water soluble. So it can be excreted to the
So
kidney.
the word I'm looking for is actually apa nama photo oxidation.
Bilirubin.
Photo oxidation. Okay, fine. What's the term?
Is it bilirubin, doctor?
So basically the problem is, unconjugated bilirubin is lipophilic but hydrophobic. So when it's lipophilic and hydrophobic, it doesn't go into, it's not excreted by your enterohepatic circulation. It doesn't cross, it's not excreted through your urine. So the problem, and then as it is lipophilic, it crosses the blood-brain barrier and can cause bilirubin encephalopathy. So what phototherapy does, it photoisomerizes. So the term is photoisomerization. So it photoisomerizes the bilirubin, the unconjugated bilirubin, that it becomes water soluble. It becomes hydrophilic. So when it becomes hydrophilic, then it can be excreted through your enterohepatic circulation, and it can be excreted to the urine. Give me 1 second.